We're going to cover myths that surround inflammatory disease, the transition from, especially for the pediatric AID patient, into adulthood and their care, and then some issues about physician education and how to get the patient into the right physician. So,
to start off, I wondered how many adult rheumatologists we have in the audience. Can you raise your hand? Looks like we have one. Okay.
two.
And yeah, there's three. But
There we go.
Okay.
So we're preaching to anybody but the choir.
That's right. Exactly. So we wanted around a healthcare transition was really what the needs does a pediatric patient have? How can the pediatric physician facilitate transition? What does the adult rheumatologist need to do or know when accepting the pediatric patient? And how can one acquaint physicians with rare autoinflammatory diseases? And how can one raise awareness? And how can we address finding adult physicians who takes on a pediatric autoinflammatory patient? So we want to commend the adult person that's in the room. Thank you.
What we'd like to do is kind of go through these fast. These are some of our ideas about this. I think the myths part should be easy for everyone, and then give you some early approaches, but really hear from you. Like the question we came up earlier: how do I get testing done, or how do I get financial support for the drug that's not indicated and whatnot? And hear some of our impressions, but also hear some of the impressions of other people in the audience and how they deal with these kind of difficulties and sticky issues. So, patient 22 to start off.
Okay, so I'm going to read these questions. Monogenic periodic fever syndromes present exclusively in infants and children. What is the answer to that?
Well, good news for for us adults, we're glad it's false because otherwise we wouldn't see them at all. But I think it's true that most adults have to get a lot of their education on these matters from their pediatric colleagues. We're not going to see CAPS patients. We know we hear a lot about it. What's wrong?
This is crackling. You're making noise.
Oh, it sounded fine to me. What's that? Okay. I'm loud either way. So I think that again, that the point behind that, of course, is that the bridge between pediatric and adult rheumatologic care could always be better. And I think this is a great area where we're interested. You want to share. And there are examples certainly where they may occur in adulthood as well. So the next one.
Children with PFS and AID outgrow symptoms and do not require lifelong treatment.
Well, there certainly are many that will remit, and that's what we certainly teach with systemic patients. But there are other AIDs that will go on for a long time. And in our group at UT Southwestern, there is a transfer over of care. Usually when the patient gets taller than the pediatrician, when there's pregnancy or criminal record involved, they have some very hard and fast rules. Otherwise, our pediatric rheumatologists tend to hold on to those adolescents that are still dealing with these disorders.
A negative family history of PFS-AID rules out the possibility of PFS-AID.
I think that's something we learned throughout many lectures today, that doesn't have to be truly inheritable to be considered an autoinflammatory disorder.
A negative genetic test for pathogenic variants excludes the diagnosis of PFS-AID. We heard a lot about that today, too.
Sure, and I think what we heard was it depends on which testing you're doing and what you're looking for. We had a situation where there was a company that was doing a clinical trial, and it wanted it to be in FMF and CAPS patients, and they wanted the patient to have a genetic test confirming the diagnosis. And I was one of the sites they were recruiting, and I was telling them, well, that's sort of an impossible trial to recruit for because I can't routinely get those tests. It's really very, very difficult. And the vast majority of adult rheumatologists have no clue. and I'm someone who already is working in the area, I think many pediatric rheumatologists also have a difficulty in getting tested. Once you figure it out, it gets a little easier, but every patient, every insurance program becomes a challenge.
Lack of benefit from NSAID steroids, colchicine rules out an AID diagnosis. Now, we learned that today. Is it true?
Right. Well, and I think that while cost and prudence dictates that we should try colchicine where it's indicated, because it's dirt. Well, it used to be dirt cheap, and then it got be very expensive dirt that I actually get from Canada rather than pay for it in the United States. But it makes sense to try NSAIDs or colchicine where indicated. But frankly, in many disorders, it does make sense to go right to the drug that's been proven to work the best. Why not use your best drug first? Is sort of my rule. The main reason is the cost and care, but that's an issue for insurance coverage versus no insurance coverage.
Infrequent flares of AID do not lead to long-term complications.
Yeah, not necessarily true, especially with the issue of amyloidosis. I was reared with the belief, reared in medicine, that is, with the belief that we don't see amyloidosis very much on this side of the Atlantic, in our stills or systemic patients, or in the CAPS patients, and the longer I do it, the more I find out how wrong that is, and it really isn't necessarily related to how severe the disease was. So certainly long-term complications like amyloid are things that need to always be looked for by someone who knows what they're doing.
All right, so let's just do a quick summary. Go right ahead. Around transition here. Sorry, let's go back one. So I think why are we here? I mean, the evidence is pretty clear that there's a lot of trouble around transition. There are a lot of medical complications, medication adherence. Discontinuity of care is probably a big one. As you can see down below, this is a series of following up patients, pediatric patients, and did they show up on the adult side? We have to remember that the no-show rate of adolescents or young adults, I think it's in their 20s, runs about 50 to 60% anyway. And then, of course, these young people have an illness as well. So the other, I think, a major thing is of issues in healthcare transition, it really reflects in this picture that's difficult for all of us, is that teenagers are not really interested in what you have to say, as you know, and they're certainly not interested in managing their own disease. So that sort of throws a wrench into everything we think about. If you can find medical care up there on the top of that brain, I would really be interested. You could tell me. So what are the things that really upset families and youth? These are large reviews, and this comes from the most recent American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians have gotten together and put together a clinical report. I commend you to this. It's a great review and really goes through all the issues. So families really have a hard time leaving the pediatric folks in this room for obvious reasons. You're wonderful and have done a great job. But they realize they have no clue what's coming. There's not a lot of planning going on, and a lot of these families want a lot of planning. They've had to live with these illnesses for a long time, and there are a lot of system difficulties. The issue of communication is going to come up over and over and over again, and coordination and transfer of records. What's the one thing the adult rheumatologist wants?
Money?
Yeah. Next?
Love.
No, you're doing poorly here.
Snickers? What? I'm lost.
Medical records.
Oh, yeah.
Okay, great. All right. So how about barriers that pediatric adult rheumatology? This is a CARA survey plus an adult rheumatology survey and the rest of the literature. And once again, you're seeing the lack of communication. And interestingly enough, there seems to be not a lot of knowledge about what's out there that's available around healthcare transition. What are the tools and what are the things that you can use? A lot of trouble. That the number one thing that pediatric folks often admit to is that they have a hard time letting go of these families that they've taken care of for a long time. And clearly, their training limitations. I think as adult rheumatologists right off the bat would say we have a lot to learn from you and want to learn from you, as I think you mentioned earlier. Certainly there's a lot of trouble with care coordination. I want to point out quickly that the environment that the pediatric rheumatologist works in is something that's not available in the adult environment. There is no care coordination. There are no social workers. Do you have a social worker in your clinic?
No, I don't.
Oh, gee.
You have to be in a university, hospital, or a big medical center to have
Exactly.
access to that.
And so think of the infrastructure issues when you're calling somebody with a really complex young person. And it also is very hard for adult folks to get used to the fact that often the young person wasn't prepared, doesn't really know what they have, and is not very interested in talking to you sometimes as well.
Well, you said that we're interested in learning and learning from you. We're really not. We don't want more work. We got plenty of work, and getting a patient with a fascinoma disease is interesting to a minority of most rheumatologists, and so jumping into that pool is something that most people really don't want to do. So if someone has an ADA2 deficiency and they want to send to an adult rheumatologist, in my community, most rheumatologists would say either no or send it to Jack Cush. Maybe he's seen one of those. And so the idea here is it's the bridge is easiest when you have the relationship. I have a relationship with my pediatric rheumatologist because I did a lot of training and went to their clinics, and so they know, and I know they have an interest here. So I'm the easy phone call, but again, those relationships don't often exist, and it's forming them that's going to pave the way, which is going to lead to better care for the patient.
Yeah, in large surveys we did of integrated systems, the people that are most interested are people who are recently out of their training. So think about the rheumatology adult fellows that are coming out of their training and are going into practice. They're interested in increasing the patients that they see, and they're more likely to perhaps have seen some of the patients that you have. So instead of calling your friends that you're now 50 and they're 50 and their practices are full, think of the younger folks that are coming out. Just so we're all on the same page, I think that, remember, transition is moving from child to an adult model of health care. That means at age 18, families really shouldn't be in the room unless you have some real reason to have them there. And I think that's an issue that happens in the adult environment with HIPAA and all the other things that we're faced with in that setting. And you have two goals really in transition. One is to make the young person to manage their own health and use health services. This is a complicated system that we're working in the US and anywhere to make sure they know how to use it, and then obviously having an organized clinical process. A myth about transition is that it equals transfer or just planning. The one thing you take home today is a 3-phase process. There's planning, there's transfer, and then there's integration that we're talking about a little bit here.
So that transition and getting the adolescent to become an adult is very difficult. I can tell you the first few visits with almost all of them in my clinic, I'm asking the patient the question who's sitting here, mom's answering the question behind me, and the patient is tight-lipped, clammed up, doesn't want to be in the room, and mom's answering the question. I just turn around and give mom the evil eye and say, I'm sorry, but I think I was talking to her, and so I start to force the adolescent to get involved, and usually by the second or third visit it works, but and I don't know that a lot of doctors want to do that. I mean, I think again it's a time issue. I need my information. Whoever's going to give it, I'm going to write it down and let the little girl clam up or whatever, and that's really not a good idea as far as transferring care, transferring responsibility.
And in large surveys of pediatric and pediatric subspecialists, less than 50% have see the patient alone at any time. So this is a setup. You need to do that if you're going to be sending them on into the adult service here. So what about the national survey? How are we all doing? This is a national survey that's done every year in this country. 17% of youth, this is of families of 12 to 17-year-olds, 70% of youth actually have ever heard of transition guidance or planning. So we've got a lot of opportunity here to make some improvement. Now, what do we know about transition? We've done a couple of systematic reviews, and you can see here with a structured process, you can get statistically significant positive outcomes in all these areas. This was not done in youth without special needs here, but you're going to get adherence to care, more satisfaction, a decrease in the time between the pediatric and adult visit, and a decrease in ER and hospital admissions. So we sort of know this. There are a lot of studies in multiple diseases that show us this. So the question is developing that structured process. This is the original clinical report. It set up an algorithm sort of talking, you should begin the process at 12. You're thinking of asking them to leave a practice around 21, 22 or so, with a lot of steps in between. This is just showing you that everybody has a job in this. We often get the story that, okay, the adult providers just say, just send them on over. And I'm always saying, no, that doesn't work. Everybody has to plan together. You need to communicate across this. And they need to do an awful lot of work around welcoming this young person and thinking about how to do it, as you were just talking about. How do you communicate with this young person? But you can see it's a 6 sort of step process. It's called the 6 core elements. You can look this up at godtransition.org. You have a lot of opportunity here to get tools and all sorts of things about self-care, as well as registries and examples of policies. And the ACP, along with a lot of subspecialties, sat down and actually looked at the gut transition tools and customized them. Here are the set that the American College of Rheumatology did. And as we'll talk a little bit later, this is something that you might think in this community you might think of doing, is actually getting these kinds of things together going here. So there are practice resources here. I want to call out a app that OK has put together for really doing a readiness assessment on the phone and being able to set up a problem list. But there's a lot of information out there, just a huge amount. And your practice resources, he brought up the payment issue. We have every year we update a coding and reimbursement. It has vignettes. It really tells you how you can code for these things. It doesn't mean insurance companies will pay for them, but like anything, if you don't ask, you never know. So I think it's a really important, if you want to do NCQA, those kinds of things, there's a lot of information available for you.
What I find interesting is that I do a fair number of educational programs for adult rheumatologists that I run and sort of put together, and have worked with 3 separate, very good pediatric rheumatologists in the last just year, and asked them to address just pediatric rheumatology for the adult rheumatologist. And I was surprised to see that all 3 of them spent at least 5 slides on the issue of transition, which I thought was really impressive, and really thoughtful, sort of comprehensive approaches that at least let the adult rheumatologist know that it's not enough to know that what we used to call POSI is now oligo, and there's different kinds of oligo arthritis, but that you now need to know about how to hand off the patient. So this is the idea, is that there are toolboxes for JIA and for SLE on how the patient should be transferred over. Why not one for the systemic JIAs, those with systemic autoinflammatory disease? And, this is actually a possible slide, and we thank him for many of the slides he's provided for this. But one would be just to have a transition letter. Second would be to have a medical summary, and third would be a fact sheet relative to that patient's diagnosis. But these are resources that you, the pediatric rheumatologist, would need in just gathering things up and sending this patient who has FMF on to the rheumatologist, the adult rheumatologist, Dr. Baker. At least it gives him a starting point. 2, it now defines that you're the go-to person, the expert, that he can now collaborate with in the care of that individual. And I think that's going to help him take on the patient, and again, foster the relationship between the pediatric and the adult rheumatologist.
Yeah, and try to see the patient alone, so that makes it a little bit easier in the transition. That'll be very helpful for the adult rheumatologist and the adult system, and get the young person to begin to think about how they can quickly tell about their disease a little bit. They're going to have to do it for the next 50 years or so.
And I can tell you, we're not in a rush to see them alone, because vast majority of them don't want to be there, and we want someone responsible in the room. We want someone listening in the room. So hopefully we're doing a good job of fostering independence and being the CEO of your own health and that sort of thing. It's hard enough in adults. It's going to be almost impossible in an adolescent, but it's possible, and you have to work towards it. I think that the idea of adult rheumatologist needing education, almost everyone would agree to, assuming they're going to get it from lectures and going and reading up on it either through textbooks or journal articles, is probably to be naive about this. I think that one, from a meeting like this should come out the criteria and the guidelines that everyone should be agreeing on as to how we make the diagnoses, what the approach is, what the sequence of either testing or the sequence of therapeutics should be when it comes to a particular disorder. I think that there needs to be many different models of education, and it would start out, I guess, with like that fact sheet that the pediatric rheumatologist hands to the adult rheumatologist. Having ways of getting answers quickly is not usually well worked out. Sometimes it's in my clinic it might be having a texting relationship with a dermatologist, and I can text her and say, what do I do when I have this diagnosis, and I get a quick answer, and then later on I can fill in the blanks and learn more. But I think we need maybe fact sheets that will help with that. Obviously, criteria help with that. I think modular learning programs, I think these can be built and provided to academic centers, to individuals and practices, and be made available on a website. I think it wouldn't be a bad idea to have a certification sort of thing. Dr. Kavanaugh and I have a website called Rheumatology. That's a nonprofit that's basically a textbook that we're turning into a wiki that's going to ultimately be about certification for people to do certain things, or to say I'm certified to prescribe biologic therapy or DMARD therapy, or I could be certified in managing autoinflammatory diseases. Case-based education always works. CME platforms, again, wide availability and dissemination with slide sets. I mean, this is where companies could step up and do that job. They used to do it all the time, but drug companies cannot provide services and information and things for free. But I worked with Pfizer a few years ago, and they came up with a fabulous slide set on one on pregnancy and one on vaccination, and at no benefit to them at all. Now, vaccination, wait, they do make Prevnar, but still, they made it and they put it out there, and they get for everyone to take and have for free. Incredibly well done pieces that, again, this body or the American College of Rheumatology should be doing the same sort of thing.
Yeah, you could think of podcasts, because a lot of physicians listen to those when they're in the long commutes. And I know that that's the one thing that the AAFP asked us to do, was to do podcasts around transition. So it's another thing to think about.
So we were talking about websites when we were talking with Rafaela on a conversation, and I put up a website this week called Stills Now. I have a website called Room Now, and so Stills Now, and it's supposed to be, information, how to get a referral, how to calculate diagnosis, and again, this happened this week. These are screenshots from my cell phone. It's got basically 4 buttons. Education's got grand rounds and three or four different articles to read at varying lengths. It's got a series of videos on adult Still's disease. It's got a diagnosis calculator, and that's going to have a map for referral doctors. Haven't put that together yet. That's going to take a little time. But this is what the calculator looks like. You just check boxes, and it's for doctors. It's for patients. And as soon as you check, you can see I checked a bunch of boxes. Someone had a 20-year-old who had high fevers and wrist arthritis, and but no negative ANA and rheumatoid factor, high acute phase reactants and white blood cell count, but no rash. You can see that the patient met one criteria, which was the Yamaguchi criteria, but not my criteria, the Cush criteria, and not the ILAR criteria. So that becomes, and it's supposed to prompt the person to say, now you need to be seen by an expert to confirm the diagnosis, develop a care plan. That's just one function that can come out of that. I think we should have a network, and this has not been built, but this could be built by an activity such as this, and led by the NIH. And one of the reasons is
The NIH is very, very overburdened in its clinical services for these consults. Like Ron talked about earlier, we have a lot of friends here at the NIH that we can call and say, what would you do? It's not so easy for me to get my patients into the autoinflammatory clinic here at the NIH. In fact, I failed way, way more than I've succeeded. And I'm very comfortable managing a lot of these. So I'm sending people who I think really need it, but they just can't do it. The idea is they want to develop by this kind of conference, by these kind of activities, a series of experts, multiple avenues for better care, better diagnosis. And I'm suggesting that we could do that with web-based activities by having regional approaches, what I call a hub and spoke, where you have regional leaders who are well known. And I'll just say, like, there's a person in New York City who's very well known for adult Still's disease. He needs to put together a network of doctors who he talks to, and now that's the spoke. And now he's got 15 doctors who he communicates with, and they go on a referral list. And this is a way of providing services to patients who need it, providing maybe an avenue for research, and certainly an avenue for education. And then it's also a way of developing new talent. And I think that you brought that up, patients, earlier, that it might be too hard to train all these old dogs who, Chad Deal said there's a tsunami of white-haired elderly rheumatologists about to retire, and we need new talent that's going to take over in research and education and leading the way. This would be a great topic for many of them to get involved in. So, again, a network needs to be built of the people that are going to do the work, who are going to do the education. So these are our ideas on how to approach it. We'd be happy to just entertain any questions either around the transition or around education, or maybe just some of the hard things in managing these patients. Thank you very much.
Thank you. Yes, somebody back there. The light's in our eyes, so it's something.
So what I wanted to say was, before I ever got diagnosed, I went to Walmart. I was under my dad's military insurance. And my mom started me out young, having, to call the doctor's office to make my appointments. And she started stepping away from the appointments. And that might be part of your guys' system of, teaching these parents, okay, you can still be in the room, just, don't say anything and that sort of thing. But what I will say is that when I switched, the Walmart had no clue what I had. And so I got referred over to UNC. Even though I was 20, I had no clue that I could see a pediatric, because we didn't have that in the military stuff. You just saw a regular doctor. So I had no clue that there was peds for any of this. So I'm just speaking as a patient, as someone who started off young. And even though I had ulcers when I was young, and I had headaches, which now I know were migraines, when I was young, but my mom had those. And so I never questioned it. It was just, that's what I had. So could I have seen someone sooner? Possibly, but I never knew until it hit me hard in college.
So were you being forced to be independent, is what you're telling us, and it was not so easy that way?
Yes and no. I mean, luckily my parents had already, I was already making my own appointments. I was going to my own appointments. But it was a whole new world for me. It wasn't an easy transition as far as trying to get the doctors on the same page. Nobody talks to each other. Dermatologists, rheumatologists, none of that happens, especially right now I'm in Tampa and I see the USF doctors. I have TDH doctors, and then I had a dermatologist who was really good, but nobody talked to each other.
Well, that's the number one failure in all of medicine. Unless you're in a university system, nobody talks to anybody. This is why you have to be the expert of you. You have to be the repository of all your notes in all your labs. You have to carry a chart with you when you go somewhere and share it, and that's how they're going to communicate. When things get tough, then you need to force the doctors to say, hey, please call Dr. White, and you two get together because you're both giving me different, put me on the spot when that happens. But generally, we're not built that way, and it's a gigantic shortcoming of the system. I would encourage you that, you should take responsibility. I kind of like what happened to you. On the other hand, it's very important for patients to never go it alone.
Right. You should always
That-
have somebody with you.
Because you need 4 ears and 4 eyes, and you need multiple people in a room, and that's how things are going to get done.
My parents thought I had just growing pains like my sister.
Right.
No one knew what I was going through because they didn't see me during those times. But one of the things I like that you guys have for the family day is that you guys are showing them apps to be able to write down these stuff, because I had to create my own notes doc, because when you're sick, you start forgetting exactly what order they happened in, or different stuff, and the only way I remember is because it's written down, and I have photographs of everything.
Yeah, it's important. Phone is a great thing, and almost all the young people that I see, if you got an iPhone, there's an easy component, that has that wonderful white with a red heart. You can actually put all your information there, and then a lot of the particular diseases, and we've just talked about another one, which is really about readiness, but in terms of medical records, there are a lot of apps that particular patient groups have put together. The more complex, you can put your CT scans. There's a huge amount that you can put on your phone, and it's great. They come in and see me. They actually just forward it. It comes right through my email. We download it. It gets right into the medical record. If you bring it in paper, it's very hard. I have to scan it in, and if you bring it in on a flash drive, it's no good because of the viruses, because I'm going from one EMR to the other. So, the real issue here is if we had one platform for EMRs like they do in France in some countries, where you carry around your medical records, it would be wonderful. But thank you for your comment and your question. And I think, okay.
I just have one more thing. So I have Bushettes. I have twin boys who are 9. Both are, one more than the other is getting ulcers and has headaches like constantly. And I'm glad that I came to this because, like I said, I never knew there was a peds rheumatology. And I've always wondered, where do I start? How do I find out if they have Bushettes or something similar? So maybe that's something for adult and peds to communicate.
Absolutely.
Great.
If you're
Thank you. I think
still
we're-
under military care, please let us know. Otherwise, we can provide you information on the Florida resources. Absolutely. Thank you so much.